Good afternoon, everyone, and welcome to our final day of Kidney Action Week. On behalf of the American Kidney Fund, we are so happy to have you with us. My name is Tamara Ruggiero, and I'm Vice President of Communications and Marketing here at AKF. And I have the honor of acting as your moderator during this interactive session, Understanding IgA Nephropathy, IgAN. This week has been full of exciting sessions. We've learned so much from top nephrologists, doctors, dietitians, patients, and caregivers. And I really hope everyone will be leaving this year's event with new tools and resources to help us live our healthiest lives. Before we get started, I want to encourage everyone to join the conversation wherever you may be logging in from today. So we're going to have a Q&A at the end of our time today, but you don't have to wait until then to ask your questions. You can drop your comments in the window next to or below the Facebook live stream or into the chat box below if you're here with us on the Kidney Action Week website, and we will try to answer as many as possible. I want to also take a minute to thank our session sponsor, Calliditas. We greatly appreciate their support and partnership with AKF's efforts to educate the public about IgA nephropathy. So now let me introduce our experts for today's session. We have a fantastic panel today, and it is my pleasure to introduce Dr. Jonathan Barrett, Stuart Miller, and Joseph Byrne, who are going to provide their insights on this very important subject. Welcome, everyone. So first, let me introduce Dr. Jonathan Barrett. Dr. Barrett is an incredible expert on this subject. He is the IgA Nephropathy Rare Disease Group lead for the UK National Registry of Rare Kidney Diseases, and he's a member of the steering committee for the International IgA Nephropathy Network. His research is focused on a bench-to-bedside approach to improving our understanding of the pathogenesis of IgAN, which is the common global cause of kidney failure. He works closely with pharmaceutical companies who are interested in new treatments for IgAN, and he is the chief investigator for a number of international randomized controlled phase 2 and phase 3 clinical trials for IgAN, which is particularly exciting. Dr. Barrett was a member of the FDA and American Society of Nephrology Kidney Health Initiative identifying surrogate endpoints for clinical trials in IgAN work group, and he is currently co-chair of the UK Glomerular Nephritis Clinical Study Group. He is also the IgAN lead for the recent revision of the KDIGO Clinical Practice Guidelines for glomerular diseases. Next, I would like to welcome Joseph Byrne, Health Promotion Project Officer with the U.S. Army Public Health Center. Joseph Byrne is a husband, father, friend, and two-time kidney transplant recipient. He is a U.S. Army combat veteran who served as a combat engineer, and he continues to serve as a Health Promotion Project Officer with the Army Public Health Center. He was diagnosed in 1998 with IgAN, and he subsequently underwent peritoneal dialysis and hemodialysis, as well as 2 transplants at the National Institutes of Health. Those challenges, along with the support of his family and friends, have really helped him to appreciate the opportunities that lie ahead. Spending time outdoors and competing in triathlons, swimming, traveling abroad, and enjoying nature are all driving forces in his life. And really, over the past 20 plus years, he has been fortunate to live a rigorous and fulfilling life due to the many advancements in medicine. He has spent the past 5 years living in Germany, leading resiliency and quality of life initiatives for soldiers, families, and civilians who are stationed in Europe. Welcome, Joseph. And finally, Stuart Miller, who is Director of Strategic Planning and Government Affairs at the IgAN Foundation. Stuart Miller is an advocate for NKF and an ambassador for AAKP, and recently he was appointed as the Director of Strategic Planning and Government Affairs for the IgAN Foundation. He was diagnosed with IgA nephropathy in May 2008, but making some lifestyle changes and with good care from his doctors, Stuart was able to manage his IgAN until July of 2018. And then, thanks to his wife, Carol, and the paired kidney donor exchange, Stuart was able to have a preemptive transplant at Emory Hospital in Atlanta. Stuart and his wife own a wholesale home decor business, and when he is not working, he enjoys spending time with friends, cooking, and his 2 dogs, Theodore and Oliver. and following his favorite sports teams from his hometown of Boston. He became an ambassador to help spread the word about organ donation and to encourage patients to become their own advocates and to help work on legislation that will improve the lives of others who live with kidney disease. So, don't forget to add any questions you may have for our presenters in the chat box so we can answer as many as possible at the end of our session today. So welcome to all of our presenters. And now to start us off, I'd like to turn it over to Dr. Barrett to provide an overview of IgA nephropathy. Dr. Barrett?
So thank you very much. It's a real pleasure to be here, and it's a real pleasure to be part of this fantastic event. So I'm going to give a little bit of background about IgA nephropathy, and the person you see in front of you here now is Jean Berger, and he was a Parisian pathologist who was the first person to describe this disease in 1968. And some of you may have been told you actually have Berger's or Berger's disease, which was the old name for IgA nephropathy, and it was named after this gentleman, this pathologist, who was the first kidney pathologist to actually identify the disease. But of course, IgA nephropathy has been around for longer than it was described in 1968. And in fact, the oldest two cases that we know about are these two cases here. One is John Paul Jones, who died in the late 18th century and is a very famous American. He is believed to be the father of the US Navy, and his kidneys were preserved. And when they were looked at in recent times, he was shown to have had IgA nephropathy, as was Prince Joseph Habsburg, a European nobleman who again had his kidneys examined recently, but died in the 18th century. So IgA nephropathy has been around for a long time. We've only really known about it for the last 50 years or so. In terms of the overview of what I'm going to talk about, IgA nephropathy is the commonest pattern of glomerulonephritis in the world. So in terms of the kind of kidney diseases that I look after, this is something that I see commonly. But it's important to remember, in the grand scheme of things, it is rare. And it's rare both in the US and for me in the UK. And one of the things I notice most about when I meet with patients is most patients with IgA nephropathy have never actually had the opportunity to chat to another patient with the same condition. And one of the things that we do in the UK is we bring patients together, and it's a great opportunity for them to be able to meet and talk with one another and share their own experiences. And I think that's something that I'm sure Stuart will talk about and is important work for the IgA Nephropathy Foundation. In terms of how do you know you've got IgA nephropathy? Well, one of the commonest things is that you notice that you have blood in the urine. And this is called hematuria. This is what doctors call hematuria. And you can either notice it as being present, you can see it with the naked eye, so either macroscopic or visible hematuria. And you will often notice this after you've picked up a cough or a cold. And within 24 to 48 hours, particularly young men will pee fresh red blood into the urine. It can look red like normal blood, or it can look like Coca-Cola or tea in a much more darker brown. And it usually goes away within 48 to 72 hours. But more commonly, patients with IgA nephropathy have what's called microscopic or non-visible hematuria. So you can't see it with the naked eye, but the doctors will identify it with a dipstick or when they look at the urine under a microscope. And there you will have, I would say 95% to 100% of all patients with IgA nephropathy will have this low level of blood within the urine. What else might you have in addition? Well, the other thing that we always look at, and as nephrologists we are obsessed by, is whether there is any protein in the urine. And this is called proteinuria. And again, we measure this with a dipstick, but we also collect your urine and send it off the laboratory and measure it. And we can measure the total amount of protein in the urine, or we can measure a particular protein called albumin, and we can look at albuminuria. And some of you may have measures of albumin in the urine, some of you may have measures of protein in the urine. And they're both looking for very similar things, but those are two things that we will regularly assess our patients for. In terms of other things we look for as nephrologists, as I'm sure anyone who sees a kidney doctor knows, we are obsessed with your blood pressure. And that's because damaged kidneys raise your blood pressure, but also high blood pressure damages your kidneys, and you can end up in a vicious cycle of one causing the other, which causes the other. And so we are very, very concerned about people's blood pressure. We want to manage that and keep that as best controlled as possible, not only for the health of your kidneys, but also for the health of your heart, your blood vessels. And the other way that we can sometimes identify patients with IgA nephropathy is when you go and have a blood test for some other reason, and that blood test comes back showing that your kidney function isn't working at 100%. And the thing that we look at in your blood is something called creatinine, which is something that's present in everyone's blood. But in terms when you have kidney failure or kidney damage, that level of creatinine goes up, and it's a very strong marker of abnormalities in the kidneys. And you may also be told about your GFR, which is glomerular filtration rate. And we can calculate that based upon your blood creatinine level. And one good way of thinking about GFR is that it approximates very roughly the percentage of kidney function that you have. So if your GFR is 100, you have 100% fully functioning kidneys. If your GFR is 30, then you have 30% of kidney function of what we would expect. And so that's how I talk to my patients to help them understand what that GFR number means. And as your blood creatinine level goes up, so your GFR measure goes down. So as one goes up, the other goes down. And we look at those and we assess those regularly in terms of IgA nephropathy and all other forms of kidney disease. But none of these individually prove that you have IgA nephropathy. There is a long list of potential other conditions that you could have. And so the only way at the moment that we can tell someone has IgA nephropathy is with a kidney biopsy. And in terms of the kidney biopsy, what you can see here is this is normally done by a kidney doctor using an ultrasound machine where you lie on your tummy and we take a very small piece of your kidney with what's called a biopsy gun, and you can see the kidney tissue here in the needle. It's a very fine core of tissue. And then when we look at it, we look at it under the microscope using a variety of different methods to look at the very fine filters of the kidneys and at what changes there are there. And here you can see a kidney biopsy. And here you can see those individual filters, these little balls of cells that you may be able to see here. And those are called glomeruli. They're essentially sieves that filter the blood. And you have about 1 million of those in each of your kidneys. And IgA nephropathy is a disease of these fine filters. It's a glomerulonephritis, so it's an inflammation of these fine filters. And the way that we look at that is we stain the kidney to look for this IgA protein. And what you can see here is a kidney biopsy that's been stained for IgA, and that IgA is lighting up as green. And what I hope you can see here is that each of those glomeruli within that biopsy core is lighting up with that green stain, showing that there's this IgA protein present in each of those fine filters. And the IgA is present in every single filter in both kidneys. So what is IgA? Well, IgA is one of your antibodies. It's an antibody that we all have. It's part of our immune system. It helps us protect against infections. It's particularly important at protecting against infections where the body comes into contact with the outside world. So the lining of our mouth, the linings of our lungs, the lining of our gut, all of those areas have lots and lots of IgA that is being produced, that is stopping bacteria and other pathogens coming into the body. So it has a very important healthy function. But in patients with IgA nephropathy, there are subtle changes that mean that this IgA, while also protecting against infections, is actually abnormal and depositing in our kidneys and causing this inflammation. So just to come back to terminology, because one of the things when we've asked our own patients in the UK what's so confusing and what's difficult about understanding their disease is that doctors love to use jargon. And even when we're not thinking and we're trying really hard, we invariably throw in the odd medical term because it's just the way that we're thinking. And we need to be very careful and really important that we don't use jargon. But in terms of the words you might hear, a glomerulonephritis is essentially a disease where there's inflammation of these fine filters within the kidneys. And there are lots of different types of glomerulonephritis, and IgA nephropathy is just one of those. So hopefully that explains where you might have heard glomerulonephritis, or GN is the kind of term that we use for this type of disease, but IgA nephropathy is just one form of this. As I say, it affects both of your kidneys. Even though we only biopsy one kidney, we know that that's representative of what's happening in both kidneys. In terms of what can happen. So what happens if you do develop and are shown to have IgA nephropathy? Well, it can go away completely. And this is more common in children, where there may be a short-lived period of blood and protein in the urine, and that this actually resolves spontaneously. It's far less likely to happen in adults, unfortunately. It can stay the same for many, many years. I have lots of patients who have IgA nephropathy. We diagnose them, and 10, 15, 20 years later, their kidney function is exactly the same. They may still have a little bit of blood and protein in their urine, but actually they're not developing progressive kidney damage. The kidneys may unfortunately slowly lose function, and this can happen over many years, which is why if you do have IgA nephropathy, it's important you're followed up by a kidney doctor and that you have your kidney function and your blood and urine tested regularly. It doesn't have to be every week or every month. It may only be every year, but we do need to keep an eye on your kidney function so that we can identify any changes that may occur slowly. There are cases where the kidneys will fail completely, and we're going to hear patient stories after I've given my talk about what happens in terms of requirements for dialysis and for kidney transplantation. And as a rule of thumb, it's estimated that around 3 out of every 10 patients with IgA nephropathy will have kidney failure where they need a transplant or dialysis after living with the disease for 20 years. It varies depending on a number of different things, but as a rule of thumb, it's around 30, 1 in 3, 3 out of 10, 4 out of 10 patients will be developing kidney failure after 20 years living with the disease. The other thing to say is this is a disease of the general body, not the disease specifically of the kidneys. And so there is a risk that this disease can come back if you have a kidney transplant. And clearly that's something that your kidney doctors will be looking out for if you've had a kidney transplant. But the important thing to say is, unlike some other forms of kidney disease, usually things happen very slowly in IgA nephropathy, which means we've got time to have discussions with you about treatment options. We've got time to explain what's happening, and you've got time to be able to understand and ask questions of your doctors. So you have a much better understanding of the disease and how you're going to live with this disease, and how you're going to get on with your life, most importantly, and live a full and fulfilling life while also having IgA nephropathy. So what is the cause of IgA nephropathy? Well, the blunt answer is we don't know. We know a lot more than we did 10 years ago, it's fair to say. We're making really great progress, particularly with the advances in technology that we're able to apply in terms of scientific research. And we are now identifying changes within the kidney and within the immune system that is allowing us to develop new drugs to target this disease in ways we never thought possible before. And it's fair to say we are in a golden age of new therapies in IgA nephropathy, with more clinical trials of new therapies happening now than have ever happened in the last 50 years of knowing about this disease. We know that the IgA molecules that actually deposit in the kidneys are subtly different in patients with IgA nephropathy. We know that they're more sticky, they stick together more, they stick to other proteins, and they stick in your fine filters. And that seems to be the fundamental problem. And we know that there are actually differences in the way these IgA proteins are produced by the immune system. And in particular, we think we know that the major site of this abnormal IgA production is coming from those cells that live in the lining of our gut and possibly our lung and our upper respiratory tract. So we know where these cells are. We need to target our drugs to try and stop them from producing this IgA and then stop that from sticking within the kidneys. So what is the right treatment? That's, of course, what everyone wants to know. And in terms of, as I say, nephrologists are obsessed with blood pressure. The absolute fundamental is to get blood pressure under control. and you can do a lot for yourself to get your blood pressure under control. Exercise is good, being the ideal weight, restricting the amount of sodium that you have in your diet, not smoking. And if all of these fail to have get the blood pressure to completely within the target, then you may need blood pressure reducing tablets. But all of these lifestyle modifications, we know because we've tested them in studies, really improve the outcome of patients with IgA nephropathy, but also with people with other forms of kidney disease. So it's really important. These are things that you can do for yourself and have complete control over, and be able to modify to help yourself and help your kidneys. In terms of blood pressure lowering, there are two medications that we know of, two types of medications we know that both help reduce your blood pressure, but also have a really good effect on reducing protein in the urine. And we know that drugs and processes that reduce protein in the urine will protect kidneys against long-term damage. And those two drugs are ACE inhibitors. And so these are a class of drugs that always end with the 5 letters pril. So it's ramipril, lisinopril, captopril, enalapril. So if you're on a pril type drug, you're on an ACE inhibitor, that's exactly the type of drug that we would want to use to either control your blood pressure, if it needs controlling, or even in people with normal blood pressure, we would start a drug like this to reduce the amount of protein in the urine. The other alternative that work just as well are called ARBs, or angiotensin receptor blockers, and these always end in sartan. So losartan, candesartan, valsartan. We know that either an ACE inhibitor or an ARB are very good at reducing blood pressure and very good at reducing protein levels in the urine. So these are kind of my go-to medications in patients with IgA nephropathy. What other treatments might there be that we could try if you're still at risk of progressing despite all of those things? Well, a lot of you may have experienced or been prescribed steroids. These are designed to reduce inflammation within the kidneys and modify the immune system. It's really challenging to know which patients might benefit, how long should you give these drugs, and it's certainly a very controversial area in terms of nephrology, with some nephrologists wanting to use these in a lot of their patients and other nephrologists not choosing to use them at all because they are associated with significant side effects. Are there any specific treatments? Well, if I was giving this talk this time last year, I would have had to say no, but actually we have the first approved, FDA-approved treatment for IgA nephropathy available now. In the US, it's just been given approval in the European Union, and hopefully I'll be able to prescribe it for my patients shortly. I was involved in the trials of this drug. This is a very specific type of drug that targets those immune cells in your gut to switch off the production of pathogenic IgA. It's called Tarpeyo, and it is available in the US at the moment, and is really the beginnings of some really exciting times in IgA, because I expect to see a number of other therapies be approved by the FDA and other regulators for the treatment of IgA nephropathy over the coming years. As I say, there are more clinical trials, and what I would say, and what I do with all my patients, is for me, the best thing that I can do for my patients is to offer them the opportunity to be involved in a clinical study, because it will offer those patients access to therapies that are not available at the moment, but it will also help us understand as a global community how best to treat IgA nephropathy going forwards. So I would like to say this is my view out of my office window in Leicester, but anyone who's been to the UK and Leicester will know it's not like this at all. But this is really trying to encapsulate what the outlook is like for IgA nephropathy and patients. We are, as I say, in a golden age of new therapies. We have fantastic opportunities for new therapies, all doing slightly different things, which means we may be able to combine them to get better benefit for patients. So it is, as I say, a really exciting time. And I think that we are going to transform the lives of patients with IgA nephropathy over the next few years. So key takeaways from this, I think IgA is an important global cause of kidney failure. It commonly affects young adults, often asymptomatic and diagnosed by chance, and we can only really diagnose it with kidney biopsy at the moment. As you've heard me say many times, key priorities are controlling blood pressure and reducing proteinuria, and that the future looks incredibly positive with new treatments available. Our very first ever treatment approved by the FDA late last year for IgA nephropathy. Of course, what my patients want most is they want to be able to get reliable information, as do all kidney patients. Where can we get that from? Well, social media is a good place to start. There are some very good Facebook groups. This is the UK Facebook group that one of my patients set up, and there are other Facebook groups where you can exchange ideas and talk to other patients with IgA. There are patient information days. We run a regular one in the UK, but I'm sure you're going to hear much more about the Spark event that is happening in Nashville later this year, run by the IgA Nephropathy Foundation. Here you can see, if you go onto their website, there's lots of great information there for patients. There's a great patient booklet that allows you to understand your disease and how you might manage your disease. And if you're interested in finding out more, my research group have a YouTube page, the Leicester IgA Nephropathy Research Group. There's lots of interesting resources about living with IgA, patients talking about living with the disease. We're only going to tackle this disease as a global community. And I think it's fantastic that the IgA Nephropathy Foundation is a global foundation. And I work very closely with it to connect patients together from across the world, to collect research groups across the world, because I think it's a global problem and we need a global solution. So I think it's really fantastic you've let me talk to you today, and I'm very happy to take some questions at the end of the session. So thank you very much.
Thank you, Dr. Barrett. That was a very interesting overview, and it's particularly exciting to hear about the research advances that are happening. I was wondering if you could just discuss a little bit about what you see as the human impact of this disease and how we can address the unmet needs of patients who are living with IgAN as well as their caregivers.
So a great question, but I'm acutely aware that I'm going to be followed by two people who are more expert than me at talking about the impact of the disease, because we have two patients, and that's where I go to. The patients are the experts of living with this disease. And practicing as a doctor, I know that no two people are the same. And so you need to, as a patient, you need to have a good relationship with your nephrologist, to be able to, so the nephrologist understands how the disease is impacting on you. It has physical impact. We hear a lot from our patients about fatigue, about inability to enjoy the normal activities of life that are important to them. We hear about the impact of mental health, and the fact that actually you're telling a young person they have a disease. We don't quite know what's causing it. We don't necessarily at the moment have good treatments. And there's a real risk that you might end up with kidney failure. And that can be life-changing for people, particularly at a young stage in their life where they might be planning families, they want to develop their career, they're going to think about buying a house, all the things that come with that. So I think it takes its physical and mental toll on patients. And the real challenge of any rare kidney disease or any rare disease is access to other people in the same situation, being able to talk and having that peer support. And that's why I think patient groups, the IgA Nephropathy Foundation, and other groups around the world are really key to helping support patients, to help them understand they're not alone. And of course, we can help as clinicians, but we are just a small piece of that jigsaw. And we need to be able to connect our patients with all of the resources they need to be able to live with this disease and have a fulfilling life and be able to do all the things that they want to do.
Thank you, Dr. Barrett. Like you said, the patients really are the experts in living with this disease. And so now I'll turn it to Joseph Byrne, who's joined us today to share his journey with IgAN. Joseph, can you tell us about your background and your experience living with IgAN?
Yeah, certainly. First, I want to thank you for including me in today's conversation, and thank you for that amazing overview from Dr. Barrett. I think, you know, having lived with IgAN since 1998, and all the information I've absorbed, I've even still learned stuff today listening to Dr. Barrett, so I appreciate that overview and the information being shared. As far as myself and living with IgAN, first of all, as you mentioned in the opening in my biography, I was formerly a soldier in the United States Army. I retired from that, medically retired from that, and I still work with the U.S. Army as a DA civilian, and I've been doing that as a health promotion project officer for the Army, which is really a great opportunity for me to give back to the families, the soldiers, and the civilians who do support our nation. So with that, I was diagnosed in 1999 with IgA nephropathy. In 1998, that is, and then at that point, I was medically retired from the military, and I had my first kidney transplant, where my brother actually donated a kidney. I had a living donor transplant in 1999. I'm very fortunate there, and with that, you know. The very first transplant was definitely a challenge. You know, you'd unknown what to expect, what's coming. I had a career, and all of a sudden I was told, hey, your career's over. You know, you're not only not going to do this anymore. I have a wife and 3 kids, so I support my family, and plus you have a disease process. As Dr. Vera mentioned, the doctors at that point in time told me, probably be about 10 or so years generally speaking, that this IgA would progress. Unfortunately for me, I had rapid progressing IgA, and within the next 3 to 4 months, I was on dialysis. So I had some things come at me very quickly. Fortunately, though, I had a really strong support group in my family, my community, even the people I worked with in the Army, not just at that time, but the people I had worked with before. When they found out, they were very supportive. I can't tell you how many people I'm grateful to just for reaching out and saying, hey, how are you? What can we do to help? And just talking with me, and sharing, maybe some of their trials and tribulations that kind of helped encourage me to get through it. That being said, with my disease process, I did get a kidney transplant from my brother, and then I moved on from there, and I was living my life, went back to work, but I contracted coccidioidomycosis when I lived in El Paso, Texas. Had to have amphotericin B to treat that, which amphotericin B is toxic to the kidneys, and so I lost my transplanted kidney. And subsequently, I was on hemodialysis, and when I was on hemodialysis, a gentleman who I knew had volunteered to be a donor, and Mr. Rick Yates donated me his kidney, and that was in 2006. And for the last 15 years, I've been, doing well on the kidney that was donated to me by Mr. Yates. Just to give some people a sense of, some of the things Dr. Barrett said in that picture with the people sitting on the beach and relaxing and just having a good time. As mentioned in my biography, and my bio up front, is I enjoy triathlon and everything. Since my kidney transplant in 2006, I've done 3 half Ironmans. We've run numerous marathons, and done some things that I didn't even do prior to having a kidney transplant. So just saying that to let everybody know that there is plenty of fun, life, hope, and after being diagnosed, it's just a matter of your approach, and also, as Dr. Barrett mentioned, is just having that good connection with your clinician and sharing those challenges you may have, whether they're physical, mental, whatever those challenges may be, and working through those. And with that, currently, unfortunately, I'll tell you, I've had my kidney for 15 years. Currently, my kidney's not doing well, and I'm actually in line to potentially have another transplant. As a matter of fact, on June 22nd, I'll be seeing the transplant team here in San Antonio at Methodist Specialty Care to do a transplant consult. I fortunately have a couple of donors that are willing to be tested, so we'll see where it goes from there. But all that being said, I'm confident that the doctors and the technology are moving forward, and there's great hope for me with that. And 2, that it's just having a support network that I have and the people around me is going to lead me through whatever challenges lie ahead.
Thank you for sharing your story with us, Joseph. I think it's fantastic that you've been able to live such a full and active life in the face of this disease, and certainly want to wish you all the best with your transplant evaluation. So we have a lot of questions flowing in already. This is really going to be a great Q&A. If you're just joining us, thank you for being part of Kidney Action Week. You are tuned into our session, Understanding IgA Nephropathy. So please add your questions in the chat box now so we don't miss them. And with that, I'm going to turn it over to Stuart. Stuart, could you speak about the many resources for patients that the IgAN Foundation has?
Hi, Tamara. Yes, thanks. Thanks again to AKF for inviting us to be part of this board. The foundation has lots of tools and resources for our patients. Most of them can be found on our website at www.igan.org. One that Dr. Barrett mentioned is a 32-page toolkit or patient guide to living with IgA nephropathy. It was developed in partnership with Calliditas, and so we appreciate their support. And it's a great tool from everybody who has been recently diagnosed to existing patients to help them really navigate their journey. Being a patient, I wish that this guide had existed when I was first diagnosed, because it's kind of scary. You know, when you get diagnosed initially and you don't really have a place to go and you don't have enough information on the disease. So we're really excited about this guide. We just published it in November of last year, and we're in the process of updating it again in probably a month or so at our annual patient conference in Nashville called Spark. In addition to that, we have a patient support group that meets the first Monday of every month. It's led by two patients, IgAN patients. One has been transplanted and one has not. And it's a great opportunity to meet other people and to interact with other people who have the disease and ask questions and learn what it's like to live with IgA nephropathy. And I would strongly encourage anybody watching who has any questions, who wants to be a part of that. Again, they can go to our website and find the link to our patient group. In addition to that, we have two Facebook groups. One has run by the foundation, has about 6,000 patients in it. And the other one is a clinical trials IgA nephropathy page on Facebook. Both of those, again, are great resources for patients who have IgA nephropathy and want to talk with other patients. Dr. Barrett mentioned how important that is when you get diagnosed and you get this rare disease and you've never met anybody else that's had it. You know, what is it going to be like to live with a disease, and what are the consequences? And it's great to be able to have those resources to find other people who can answer those questions for you. In addition to that, we have a couple other tools on our website. One we just added called Tracking Your Treatment, which is a great downloadable PDF people can use to help manage the treatment when they meet with their doctors and go to talk with their doctors. And then the other is called Navigating IgA Nephropathy and its Treatment Decisions. So it's full of questions that you can ask your doctor, information to track your treatments, keep track of all your doctor's appointments and things that happen when you have IgA. And again, those are all available on our website. And last but not least is coming up, we have in July 24th and 25th in Nashville, we're having our first live patient conference called Spark. We've had the last 2 years, we had to do it virtually, but this is our first live conference. And it's a great opportunity to meet people who have IgA nephropathy, to learn about it. We have some great leaders that will be key kidney opinion leaders that will be leading some topics, including Dr. Barrett. You can learn about reading your biopsy, understanding your labs. We're going to have 2 patient panels that will be made up of IgAN patients and hearing their stories. And for me, it's just a great way to feel like you know some other people that have the disease and know what it's like to live with it.
Thank you. Thank you so much. And Stuart, those were a wonderful overview of the resources of the IgAN Foundation. And I understand you have a short video about the foundation that I think we wanted to show.
Sure.
You know, if I get a little emotional, I guess. It's been, we're very, very lucky. It's a little scary. I mean, when someone says to you, listen, you have this disease that you've never heard of before, and you really, there's no known treatment for it.
It's overwhelming to an individual to know that you have a chronic disease and that it's going to take over one of your organs.
What I always tell people is I have an autoimmune disease that attacks my kidneys.
Since it is a disease that doesn't show on the outside of you, people are first to assume you're doing this for attention. You don't actually have this. This is fake.
So when I was first diagnosed, me and my mom were just kind of doing some research, and I went on Facebook and just kind of searched for it. So I just joined it, and honestly, just like really meaningful to be able to meet people going through it, and like, because I feel like I have some sort of connection to them, and like they understand and I understand.
I didn't know what IgA was before I was diagnosed, and many people still don't know what it is when you tell them that you have it. So it's really nice just to be around people who understand it a little bit more and understand how it affects you and what can happen. So
I think it's important to see people that have IgAN know that you can live a happy life. You can be productive. It's a struggle in the beginning, and it's overwhelming in the beginning, but after you can live a good life.
You know, we're all in the same boat, and we're all fighting for the same mission.
The IgA Foundation website actually has links to credible resources. Yeah, arm yourself with knowledge, because that's going to be your greatest empowerment with your disease process.
Wonderful. That was a great video. And thank you, Stuart, for sharing those resources with our audience. Thank you very much. So we are now going to open up for questions. So once again, to our audience, we will be answering your questions. We've had quite a few coming in. Feel free to type your questions and comments into the window next to or below the Facebook Live video stream or in the chat box on our website, and we'll try to answer as many as possible. So we had a couple of questions about heredity. And so for Dr. Barrett, I think our first question is, have there been any further discoveries about IgAN in regards to heredity?
So I think there are, so the first thing to say is that IgA nephropathy is by far the most commonly is a sporadic disease, and by that I mean that it doesn't run in families. So it is obvious, is a question I get asked a lot. If I have IgA nephropathy, will I pass it on to my kids? And for the vast majority of patients, you're not going to be passing this on to your children. There are some rare families where IgA nephropathy does run in families, but for every 100 patients with IgA nephropathy that I see, it's only one case where I see that the disease has run in families. And it's often very obvious when you talk to patients and their families that that's something that has been identified. But for the vast majority of patients, it doesn't run in families. That doesn't mean to say there aren't genetic contributions to the development of the disease. And we found a range of genes that can impact on whether you develop the disease. Not enough to produce a genetic test, not enough to predict whether someone's going to have this disease in the future at the moment. But there is undoubtedly a genetic contribution, but not to the point where you are going to be passing this on to your children, or that we can use as a test at the moment to identify whether you have IgA nephropathy.
Interesting. Thank you. Thank you for that. And then also, another question for you, Dr. Barrett, is about a symptom. Somebody asked if a rash can be a common symptom of IgAN, specifically a rash that has like a papery appearance. I guess they heard this from a doctor at some point.
Okay, so IgA nephropathy is very closely linked to another disease called IgA vasculitis, and that used to be called Henoch-Schönlein purpura, or HSP. And that is associated with a rash. It's a rash that commonly happens on the legs and on the buttocks. And it's usually a rash where you get raised bruises almost of little pockets of blood under the skin. and it comes in waves and crops across the body and then disappears by itself. And it's a very common condition that you see in pediatrics. But it also affects the kidneys. And if you do a kidney biopsy, it looks identical to IgA nephropathy. So in terms of that type of rash, I will often see patients and I'll chat to them and they'll have a diagnosis of IgA nephropathy. They'll have no rash at that time, but they'll say, do you know what, when I was a child 10 years ago, I did go to see my doctor and I did have this rash appear and then disappear. And actually what's happened is that they've slowly been developing kidney damage over that period of time, and we've only just identified it so many years later. So that's a very particular situation. The kind of rash that I think your patient is describing, as you get progressive kidney damage, you are prone, from whatever cause, you are prone to develop certain conditions of the skin. The skin often gets very dry, it gets very itchy, and you can develop a form of dermatitis or inflammation of the skin, but that's generic to all forms of kidney disease rather than specifically to IgA nephropathy.
Thank you. Thank you. That was very interesting and helpful. Another question that came in also for Dr. Barrett, how is anemia addressed in the care of an IgAN patient?
So anemia is a common complication of all forms of progressive kidney disease. And that's because the kidneys produce a hormone called erythropoietin, or EPO, and that is the hormone that tells your bone marrow to make red blood cells and to keep your blood count up. And as your kidneys get more scarred and more damaged, you become more and more deficient in this hormone EPO. And so when we start seeing anemia, we usually start seeing anemia when the kidney function is getting down below 30, down below to 20, to the levels of 20s and usually lower. So that's the GFR. And again, if you remember, I said if your GFR is 20, then that equates to around 20% kidney function. So it's a very common problem as you get progressive kidney failure. And the way we treat that is we make sure that you have enough iron in your bloodstream to be able to make red blood cells, because you need enough iron to make hemoglobin, which is the thing that carries the oxygen around the blood. And then we can give you erythropoietin, this hormone that you're deficient in, as an injection under the skin. And so a lot of my patients are trained to give this injection. You give it once or twice a week, all the way through to once or twice a month. And it's essentially hormone replacement therapy that corrects your blood count. And my guess is that it may well be that my other panelists may well have actually had treatment with EPO before, because they've developed quite advanced kidney failure. And I wonder whether they might like to comment on what it's like being treated with those drugs.
Yeah,
Dr. Barrett, I was treated with those drugs post-transplant, not pre-transplant, but post-transplant, and for about 6 months.
Yeah, and so for myself, I am currently on EPO. So I'm, as Dr. Barrett said, once you're below 20, so I'm at 12% right now, and my GFR is a GFR 12. So with that, I get a monthly 40 micrograms, I think it is, dose of EPO. And there is a difference. I mean, it's a difference of, like, you being able to walk up a flight of stairs without getting out of breath. For me, that's what I experience. Just, it helps me with the fatigue because the red blood cells are regenerating.
Mm-hmm. Thank you. Question for you, Stuart. You touched on this a little bit in your presentation, but for those people who've just been recently diagnosed with IgAN and are maybe feeling scared and isolated, what are some tips that you would give them?
I understand that completely, and I think the biggest tip is to try to reach out to try to find others that have been through the experience and understand what it's like to live with IgA nephropathy or to live with a rare disease. To look into our patient support groups or go on Facebook. Do as much research as you can and be your best advocate. Amazingly enough, I think a lot of nephrologists, either don't diagnose IgA nephropathy or they don't know enough about it to tell their patients about it when they do get diagnosed. That's the reason why we developed the guide. And then recently, About a month ago on IgA Awareness Day, we reached out to almost 5,000 nephrologists to try to educate them and let them know that we're available as a resource to their patients, because it's important to have a place to go so you can find as much information as possible and make educated decisions about your treatment, and be a good advocate for yourself, because if you don't ask questions and you don't learn about the disease from your doctor or from other patients, you may come up with the wrong strategy of trying to, find a solution for yourself.
Absolutely, that's really important. And just in terms of patients learning from other patients, question for Joseph, and this is more of a general one, but obviously we're living in the time of COVID, and that can't be easy as a transplant recipient. So what have you done to protect yourself? And what do you recommend to other transplant recipients who might be watching today?
So yeah, I mean, I just follow closely the CDC guidance on what you should do. Again, I'm a health promotion officer, so it's part of what I do in my work as well, is to push that out to others. So yeah, really being cognizant about where I'm at, who I'm around, what I'm doing. Things about traveling, who you're visiting, just really being just vigilant about that. But also, I think there's a two-sided coin there, right? So you also don't want to isolate yourself. It goes back to what Stuart was talking about, that connection. There's other ways to maintain connection with people, even though you may not be able to be face-to-face with them. And there's a lot of wonderful resources like IgAN.org, the AKF website, and those other connections. We talk about in my business, spiritual, physical, emotional, and social strengths, building those strengths as a primary prevention method, right? As to help you get through. And those apply to anyone, I think, dealing with IgA nephropathy or any disease process, that is, because you really, if you think about it, if you can build those strengths, and you can, make sure that those components are part of your life, you're going to have the support and the strength you need to kind of work through issues. So yeah, really, it's just being vigilant about, following the advice of the CDC when it comes, and also listening to what my doctor has to say.
Yeah, absolutely, really important. Thank you for that. Dr. Barrett, wanted to ask you one question that came in, which is there a benefit in an ACE versus an ARB for IgAN treatment?
Thanks. So the short answer is no. There's no evidence comparing that either treatment is better than the other. The key thing is to be on one of those two and on the maximal tolerated dose that you can take. So in my practice, I will start at a low dose and build that dose up, making sure the patient's able to tolerate it. And what I'm looking for here when we are increasing the dose is to make sure that the patient's blood pressure is okay, because these medications were designed to reduce blood pressure, but often we use the drug in people who don't have high blood pressure. And so we want to build the dose up and make sure we don't bring the blood pressure too low. But no, there's no evidence. I use both of them interchangeably, to be honest, in my practice.
Okay, thank you for that. And then I think one final question also for Professor Barrett. Obviously, as principal investigator for international randomized clinical trials in IgAN, you are such an expert. And at American Kidney Fund and throughout the kidney community, we're very concerned about increasing the diversity of patients who are participating in clinical trials. And I was wondering if you could talk a little bit about why it's important to have a diverse representative sample of clinical trial participants.
So I think that's a great question. And I think it's absolutely fundamental that we offer the opportunity for clinical trials to all the people within our community. And we need to develop strategies that allow us to engage with and connect with everyone in our local community, because it is important that they have and they share in the great opportunities that clinical trials deliver. And that's a fundamental of how we should be practicing medicine. But as a second part to that, we know that IgA nephropathy is a very different disease in different people, in different races, in different parts of the world. And actually, a therapy that might work well in a Caucasian individual may not work as well in someone, a South Asian patient or a patient from East Asia. And we need to know that, because we don't want to be giving drugs to patients if they're not going to work. And that will undoubtedly be related to underlying genetic factors, but there may well be other factors that mean that particular drugs are suitable to particular patients of particular ethnicities. And the only way we will know that is if we are as inclusive as we possibly can in our clinical trials. And so the good news about the IgA nephropathy studies that I'm involved in is that they are truly global studies. They are spanning South America, they are spanning North America, Europe, parts of Africa, and including Asia and Australia, New Zealand, the full globe. Now, the interesting thing about IgA nephropathy is that actually it's a rare disease in patients of African descent. So unlike other rare kidney diseases like FSGS, which are far more commoner in patients of people of African descent. So we have far less penetration in Africa in terms of our clinical trials, simply because the disease is far less common. But it's really important, I think, for doctors, both in their general clinical practice, but also when we're talking about research, that we engage with everyone in our community. So in Leicester, which is where I come from in the UK, over 50% of the Leicester City population are South Asian in origin. And we have worked incredibly hard as a collective community, working across the different populations within Leicester to ensure that everyone has access to clinical studies, that we make sure that the material we're generating is appropriate, is understandable across communities, that we engage with community leaders to ensure that we're all on the same page in terms of the importance of research, that we are looking to identify any issues that we need to address in the material we're generating or the approaches we are making, to be as inclusive as we possibly can. And I know investigators in the US are doing exactly the same thing, because I work very closely with absolutely outstanding nephrologists in the US. And it is a real important thing to get valid data, but also to ensure that every member of our community feels valued and has the same opportunities.
Yeah, exactly. And I think it's encouraging to see the increased focus on increasing diversity in clinical trials throughout the medical community. So at this point, we're getting very close to the end of our session. And so I wanted to, first of all, just say a huge thank you to all of our panelists and for everybody who joined us today. There's so much to talk about when it comes to living with kidney disease and when it comes to living with IgAN in particular. We can't wait to bring all of you back for more chats in the future. It's so exciting to see the developments that are occurring in IgAN treatment, and just really want to thank all of you for being with us today. So if you aren't already, please follow us on Facebook or send us your email through kidneyfund.org, and you'll be the first to know about other events like this. And also make sure you check out the agenda for the last 2 sessions of Kidney Action Week today. And you'll also be able to see recordings of sessions that happened earlier in the week. And as we conclude the session, you'll see a link for a quick survey in green below the screen. Please take a few minutes to fill it out and tell us how we did. Your feedback will be very useful as we plan our future sessions. And coming up next, please stay tuned for our mini session focused on mental health and kidney disease by Elle Lee, starting at 2:05 p.m. Eastern, 11:05 a.m. Pacific. And then our next main session, What is Hyperkalemia? Treatment and Management, will begin at 2:30 p.m. Eastern, 11:30 a.m. Pacific. And so we will see you then. So thank you, everyone, for joining us, and have a great rest of your afternoon.